All right, welcome back, everyone. Excited to keep moving on with our scientific session. Please take your seats so we can get started. I am pleased to introduce the moderators for this session. First, we have Dr. Jason Robertson, who's a pediatric surgeon at the Cleveland Clinic and an assistant professor of surgery at Case Western Reserve University. Also, we have Dr. Melissa Danko, who's a pediatric surgeon at the Children's Healthcare of Atlanta and Emory University. Thank you, and let's get started.
Thank you. Our first paper today will be presented by Dr. Nicholas Schmoke, a general surgery resident at Columbia University. He will be discussing assessing concordance of preoperative percutaneous core and intraoperative wedge liver biopsies in biliary atresia are both valuable.
Good morning. I'm Nicholas Schmoke. I'm a surgical resident and pediatric surgery research fellow. I'm going to be presenting on assessing concordance of preoperative percutaneous core and intraoperative wedge liver biopsies in biliary atresia are both valuable. We have no disclosures. We did this research because biliary atresia prognosis remains challenging to predict. Prognosis is traditionally based on age at the time of Kasai, your anatomic variant, syndromic versus sporadic cases, and CMV serology. However, the role of a liver biopsy in both the diagnosis and prognosis of biliary atresia remains controversial, and there's significant practice variability across institutions. We therefore aimed to evaluate the concordance and clinical utility of preoperative percutaneous core needle and intraoperative wedge biopsies in biliary atresia, and our hypothesis was that there would be a high level of concordance and that fibrosis stage would be a useful marker for prognosis. A single institution retrospective review evaluated all patients with biliary atresia who underwent a Kasai procedure between 2004 and 2023. An experienced liver pathologist evaluated all available liver pathology, including both preoperative and intraoperative biopsies, and staged the degree of fibrosis with the Botts-Ludwig scoring system. Biopsies were considered discordant if there was a greater than or equal to 1 point difference in fibrosis stage, and uni and multivariate logistic regression models analyzed the association between preoperative factors, fibrosis stage, and survival with native liver at 1 year. In total, 116 patients with biliary atresia who underwent a Kasai procedure were included, of which 87 had both preoperative and intraoperative biopsies completed, and we observed discordant results in 41% of patients. The median time between biopsies was 6 days, and there was no significant difference in timing between concordant and discordant results. Additionally, we found that the surgical wedge biopsies provided more histologic detail in 79% of patients. These are two histology slides from the same patient demonstrating discordant findings. On the left is a core needle biopsy with stage 1 portal fibrosis, and on the right is an intraoperative wedge biopsy demonstrating stage 2 to 3 bridging fibrosis. In a univariate logistic regression model, analyzing patients who survived with their native liver at 1 year, which is in the first column, versus patients who died or required a liver transplant by 1 year of age, neither the core needle biopsy fibrosis stage nor the intraoperative wedge biopsy fibrosis stage demonstrated a significant correlation. When we evaluated preoperative factors, we found that patients with a younger age at the time of surgery were more likely to survive with their native liver at 1 year. Additionally, we looked at preoperative lab values, and we found that patients with lower AST and ALT values were more likely to survive with their native liver at 1 year. In a multivariate logistic regression model, the odds of mortality or receiving a liver transplant by 2 years of age increased by 17% for each additional week that elapsed prior to Kasai, which highlights the importance of operating earlier in these patients. Our overall survival with native liver for the entire cohort at 1 year was 60%, and when we looked at an early and modern error, and the more modern error is closer to 70%. In conclusion, discordance exists between preoperative core needle and intraoperative liver biopsies in most cases. Although wedge biopsies offered more histologic detail, Fibrosis stage did not predict 1-year survival with native liver, and younger age at surgery and lower preoperative liver enzymes emerged as stronger predictors of a positive surgical outcome. Thank you so much to Dr. Stylianos, my mentors at Columbia. I'm happy to answer any questions.
Thank you very much for this very provocative presentation. Couple questions. One pertaining to the location of biopsies. Many hepatologists feel strongly that it matters where you biopsy, more centrally versus out in the periphery, which is where a wedge tends to happen, and that it's not necessarily reflective of the entirety of the liver. So any detail that you can provide in terms of that, perhaps in terms of location, might be helpful. The second thing is your observation of the 14% less positive outcome as a consequence of 1 week's delay in terms of the care is very consistent with one of the observations that we in the Western Pediatric Surgery Research Consortium, when I was in Los Angeles, had made, which was, in essence, for every day that you delay a Kasai operation, you're basically saying there's a 2% less likelihood that the Kasai will work, and therefore do the Kasai as quickly and reasonably as you can. The other thing I think is also, just as a comment, is that as part of the Childhood Liver Disease Research Network, one of the observations was that the diagnosis of biliary atresia based on ductular proliferation and fibrosis is only present in 85% of liver biopsies for patients that ultimately go on to a Kasai, and therefore 15% of the time, if you are saying it doesn't look like biliary atresia, you don't need to go to an operation, you're going to be wrong. So it raises the question of the utility of a core biopsy preoperatively to begin with. But anyway, thank you for your presentation.
Absolutely. Thank you for the remarks. We currently haven't analyzed where the core needle and wedge biopsies were taken. All wedge biopsies were periphery, which may explain some of the discordance that was observed, but definitely a good comment for moving forward. Thank you.
Yeah, a great presentation, and I'm happy to rise with a connection to Columbia, and Dr. Stylianos and I shared the same incredible mentor, Peter Altman. And part of my career, research career, was in trying to find how fibrosis could be reversed and when it's reversed over time. You said you had an opportunity to look at more detail in your wedge biopsies. Is there any evidence that you see that either the degree of inflammatory infiltrate into the porta or portal areas or pericanalicular areas made a difference for these patients, or did you just look at the hardcore fibrosis?
We looked primarily at fibrosis stage is what we were measuring with the Botts-Ludwig scoring system, and that's what we evaluated, but we did not see any impact on survival with native liver, but certainly the wedge biopsies primarily upstage the fibrosis stage when comparing to preoperative core needle. Thank you.
Okay, our next talk is going to come from Dr. Fari Fall, who is a general surgery resident at Nemours Children's Health in Delaware. Her talk is titled Utilization of Enhanced Recovery After Surgery Protocol in Pediatric Laparoscopic Sleeve Gastrectomy.
Thank you for the opportunity to present our work. We have no disclosures. The obesity epidemic has led to an increase in the number of adolescents requiring metabolic and bariatric surgery. 1 in 5 American adolescents between the ages of 12 and 19 has obesity, and obesity-related complications tend to continue into adulthood with an associated increase in morbidity and mortality. Bariatric surgery is safe and effective treatment for patients who have failed lifestyle and medical therapy. ERAS protocols, which were first described in adults, aim to improve surgical outcomes by standardizing all phases of surgical care. And recently, there has been increasing interest in investigating the feasibility of adopting adult ERAS protocols in the pediatric population. We therefore put together a multidisciplinary team, including nursing, anesthesia, nutrition, and surgery, to develop a comprehensive ERAS pathway that standardizes all phases of perioperative care for our adolescents who are undergoing laparoscopic sleeve gastrectomy. This work was done as part of a quality improvement project to reduce opioid utilization and hospital length of stay. A key barrier to discharge in our bariatric patients is the inability to tolerate adequate oral intake. Therefore, our anesthesia colleagues had the idea of introducing intraoperative lidocaine infusions for its antiemetic properties. We measured the rate of lidocaine infusion used as the process measure. For outcome measures, we tracked time to oral intake, rescue antiemetic use, opioid utilization, and hospital length of stay. Return to the system within 72 hours of discharge was tracked as a balancing measure. Key pathway elements include preoperative fasting with a carbohydrate load the morning of surgery, comprehensive antiemetic and analgesic regimen, including the intraoperative lidocaine infusion and regional anesthetic use, early oral intake, and goal-directed ambulation. The full pathway has been shared in the ABSOR Quality and Safety Toolkit. All patients who underwent laparoscopic sleeve gastrectomy from January 2019 to August 2023 were included. There were 52 patients in the pre-ERAS group and 34 in the post-implementation group. The groups were similar in age, gender, BMI, ASA class, and race. We use control charts to track the quarterly outcomes. The lidocaine infusion intervention began slightly earlier than the full ERAS initiation. And as you can see, the overall rate of intraoperative lidocaine infusion has significantly increased to an overall mean of 97% since ERAS implementation in Q4 of 2021. Time to oral intake has decreased from an overall mean of 7 hours to 4 hours. The use of rescue antiemetics, which is proxy for postoperative nausea and vomiting, has decreased from a mean of 19 milligrams to 10 milligrams. The decrease below the center line coincides with the intraoperative lidocaine infusion intervention in Q2 of 2021. Opioid utilization has also decreased from a mean of 0.22 oral morphine milligram equivalents per kilogram to 0.17. Hospital length of stay has decreased from an overall mean of 52 hours to 37 hours. There have been no returns to the system within 72 hours of discharge. We had one patient in the post-ERAS group that presented to the ED 6 days after discharge with dehydration that was managed with a fluid bolus. Our results indicate that it is safe and effective to implement adult ERAS pathways in adolescents who are undergoing bariatric surgery. We have shared our pathway in the ABSOR Quality and Safety Toolkit. Thank you again for the opportunity to present our data. Happy to take questions.
The floor is now open for questions.
Jeff Seitzman, Morgan Stanley Children's in New York. Thank you for this really valuable presentation. We have similar outcomes, and a question that I have for you is, in the preoperative preparation that patients are doing at home, such as drinking a carbohydrate drink ahead of time, do you have any numbers on how many complete every part of the protocol, say how many don't have their carbohydrates or miss some part yet still have a good outcome?
Yes, thank you for the question. That is one of the limitations of our study, and as next steps, we're working on a way to actually track all the elements, such as the outpatient stuff.
Thank you.
Thank you.
next presentation will be Remote Ischemic Conditioning Decreases the Incidence and Severity of Necrotizing Enterocolitis, Validation in a Large Animal Model. Dr. Sophia Hamidi from Nationwide Children's Hospital will be presenting.
Good morning, everyone, and thank you for the opportunity to present our work. My name is Sophia Hamidi, and I am a research fellow in the Old Toye Lab at Nationwide Children's Hospital. Today, I will be discussing remote ischemic conditioning in necrotizing enterocolitis, validation in a large animal model. These are our disclosures. NEC is a global problem affecting preterm neonates that is very well known to this audience. Briefly, it is hypothesized that derangements in the premature intestine in response to enteral feeding results in intestinal ischemia with loss of the gut mucosal barrier and subsequent bacterial translocation, causing an overwhelming systemic inflammatory response. Remote ischemic conditioning, or RIC, is one strategy to improve microcirculation via the induction of brief reversible episodes of ischemia and reperfusion in one vascular bed, which then confers global protection, rendering distant organs and tissues resistant to future ischemic injury. RIC has already been investigated in a rodent neck model by Dr. Piero's group, who found that RIC counteracts the intestinal damage of neck and improves intestinal microcirculation. We sought to validate the findings in the rodent model in a large animal model of neck in order to facilitate translation to human studies. We hypothesized that in a large animal model, RIC would also reduce the incidence and severity of neck. We delivered premature piglets at 104 days gestation, which is less than 32 weeks in the human fetus. Piglets underwent standard neonatal resuscitation, including placement of jugular venous catheters for TPN administration, as well as orogastric tubes for enteral feeding. RIC was initiated at 24 hours of life and administered daily for the duration of the study. At 96 hours, necropsy was performed for gross anatomic and histologic evaluation. Piglets were monitored in our PIG-Q for clinical signs of neck. RIC was administered via occlusion of hind limb arterial flow above systolic pressure with 4 cycles of 4 minutes of ischemia and 4 minutes of reperfusion, which were verified by color change in the hind limb. No adverse effects of RIC administration were observed during our study period. We used a validated histologic grading rubric to assess the degree of intestinal damage, with a score of 2 or greater considered diagnostic of neck. We delivered 3 litters yielding 53 premature piglets. Those that died within the first 24 hours of life or due to non-neck pathologies were excluded, resulting in 17 piglets in the control group and 26 in the RIC group. The groups were well matched in terms of weight. However, there was a significant predominance of females in the control group. With once daily RIC, we were unable to demonstrate a significant reduction in neck incidence, total histologic score, or disease severity. In light of these ideas and knowing that piglets are not large mice, we sought to investigate if increasing the frequency of RIC would improve the efficacy in neck. In the next phase of our study, we performed RIC twice daily, starting at 24 hours of life. We delivered an additional 3 litters with 54 piglets. There were ultimately 21 in the control group and 22 in the RIC group. The groups were well matched in terms of weight and sex. With twice daily RIC administration, we were able to demonstrate a significant reduction in neck incidence, a significant reduction in total histologic score, and a significant reduction in the proportion with moderate and severe disease. A limitation of our study is that these different dosing frequencies were studied in separate cohorts, so we were unable to compare the effects head-to-head. In spite of this, we were able to demonstrate that in a piglet model, RIC administered twice daily reduces the incidence and severity of neck whereas once-a-day treatment was not effective. This suggests that there may be a differential dose response in large animals as compared to rodents. These findings are significant when considering translation to human studies. In the future, we plan to compare the different dosing regimens directly, as well as explore if further increasing the frequency of treatment will enhance the effects of RIC in ameliorating NEC. Thank you all, and I'm happy to take any questions.
Agostino Piero, Toronto. First of
Hello.
all, congratulations for this brilliant study, and I'm so pleased to see that in a different animal model, this remote ischemic conditioning is effective. Obviously, this is great news for us. I wanted just to give you a little bit of an update. We started a translational trial. We demonstrated safety of this maneuver in babies with NEC down to 750 grams. And we recruited so far 17 patients. So in total, there have been 32 between the safety study and the trial itself, where this maneuver has been very safe and no other issues with recruiting patients. Going back to your study, I would like to ask you, because this is obviously a very important translational implication. We are doing at the moment with 2 consecutive days, so we do it at 24 hours apart, mainly based on the fact that previous studies have demonstrated 2 waves of an action of remote ischemic conditioning. Did you ever look at these 2 ways in your setup? And the second question, did you try to see if there was an effect on the vascular aspect or the inflammation aspect of the intestine? But thank you very much. Very, very interesting.
Thank you so much for your comments and questions. So to address your first question, we did try to kind of capture or kind of consider how these 2 waves of the effects of RIC may be coming into play. As far as within our 24 hours treatment group, seeing if there are differences as far as nutrition strategies, which I didn't really get into due to time, but we did attempt to either do RIC before starting nutrition, so as more of a preventative measure, as opposed to starting the nutrition and the induction of spontaneous NEC first, and then administering RIC to kind of see if we could capture, which one of those waves may be what's responsible for these effects. But thus far, we haven't really been able to find anything significant, but that's definitely something we're interested in and kind of looking to explore. As far as your second question, looking at the vascularity and the inflammatory components, I think especially after seeing some of the great talks that I've attended over the past few days, we definitely have some great ideas about going forward, how we can look more mechanistically into the things that we found. Thank you.
Fantastic. Thank you much. I'm looking forward to collaboration, obviously.
Me too.
Okay, our next talk is from Dr. Samantha Koenig. She's a research fellow at Children's of Alabama, and her talk today is titled Vascular Access for Renal Replacement Therapy in the Infant, a Single Center Experience.
Thank you for the opportunity to present our work today. I have no financial disclosures. I did this research to better understand the current use of vascular access for renal replacement therapy in neonates with severe kidney disease at our facility. I'm presenting it today because we want to continue to improve the care of neonates with severe renal disease. Neonatal kidney disease is an increasingly prevalent health problem, particularly in premature and low birth weight neonates. Neonatal renal replacement therapy is a treatment modality used for severe kidney failure, fluid overload, and metabolic disorders. Renal replacement therapy has historically been limited to peritoneal dialysis, but this is not an option in patients who have any intra-abdominal infection or need more rapid filtration. Hemofiltration has been limited in neonates due to their small caliber blood vessels and limited catheter options available. In 2013, our institution improved the hemofiltration circuits to deliver continuous veno-venous hemofiltration. And in 2016, we subsequently improved our vascular access with a smaller diameter catheter And in this study, we sought to provide a contemporary review of our institution's experience with vascular access and overall survival in infants who receive renal replacement therapy. We performed a retrospective chart review of neonates who received renal replacement therapy between January of 2016 and July of 2023 at our freestanding children's hospital. Demographic data, catheter data, and therapy data were collected. Outcomes including completion of therapy, transition to peritoneal dialysis, and mortality were evaluated. We limited our search to those neonates less than 5 kilograms to evaluate renal replacement therapy use in the smaller patients. An additional subgroup analysis was performed evaluating neonates less than 2 kilograms. This is a photo of our preferred 6 French cuffed tunnel dialysis catheter with distal ports at the same level, and a radiographic depiction of its use. Other catheter options we used included sizes of 6, 7, and 8 French lines, both of cuffed and uncuffed varieties. There were 93 patients identified who underwent renal replacement therapy. Median birth weight was 2.6 kilograms. Median gestational age was 36.3 weeks. Most of these infants were male and white. The most common renal diagnoses requiring renal replacement therapy was acute kidney injury. Other renal diagnoses included congenital anatomic anomalies and metabolic disorders listed here. Most patients required placement of a single vascular access catheter. 32 patients required more than one vascular access catheter, and less than 10% of our cohort required 3 or more catheter replacements, with a total of 145 catheters placed for this cohort. The most common location for placement of catheters was in the right internal jugular vein. The median age of insertion was 20 days, and the median weight at insertion was 3.3 kilograms. Catheters remained in place for a median of 16 days, and the most common reason for catheter removal was for dysfunction or malposition lines at 29%. 18% of lines, or 26 catheters, were removed for completion of therapy. 20%, or 19 patients, were transitioned to peritoneal dialysis. In our cohort, 53 patients died during their admission, which is a total of 57% of our population, none of which were associated with line placement. A majority of patients who died had acute kidney injury as their primary reason for renal replacement therapy. However, primary cause of death was pulmonary complications, such as respiratory failure, pulmonary hypertension, or pulmonary hypoplasia. We had 6 patients that had an initial vascular access catheter placed while they weighed less than 2 kilograms. Half of these patients had initial access obtained via the umbilical vein by the neonatology team, while half had initial access placed in the right internal jugular vein by the surgical team. Renal diagnoses of these patients were variable, as you can see here. None of these patients went on to peritoneal dialysis. The mortality rate of this subpopulation was 50%. The causes of death were hypoxic ischemic encephalopathy, cardiac arrest, and neck totalis. A single neonate under 2 kilograms transitioned from an umbilical vein catheter to a right internal jugular vein catheter. When comparing our less than 2 kilogram neonates to the rest of the patient population, there's no statistical difference in number of days with each catheter, and there is no statistical difference in mortality. In conclusion, this retrospective analysis is among the largest evaluations of renal replacement therapy in the neonatal population. We show that routine catheter placement for renal replacement therapy in even the smallest neonates is technically repeatable across a broad range of weights and gestational ages with similar outcomes. Our institution had previously published success with the use of smaller-sized tunneled hemofiltration catheters, as well as the use of machines for smaller extracorporeal volumes. The study expanded on these results to better evaluate the success of treating neonates with renal disease in the modern era, as well as to better define its utility in the smaller neonates, those less than 2 kilograms, which no previous study to our knowledge has examined in this detail. I'd like to thank you all for your attention, and I'm happy to take any questions.
The floor is open.
Hi, Jim Pierce, Valley Children's. I was wondering if you could talk a little bit about the umbilical vein catheterization, because you can do the cut down right above the belly button and get right in, and you'd be able to do it at the same time as the PD placement. What were the kinds of complications you saw with the umbilical vein placement, and were those the kids that successfully transitioned to PD?
Thank you for your question. Typically, the umbilical vein catheterization is performed by the neonatology team prior to any intervention by the surgical team, so that was typically done before we were even involved And typically, if we were concerned about needing the hemofiltration, it was because of a need for rapid, so the peritoneal dialysis was thought to not be efficient at that time. As far as the complications, it was typically that the umbilical vein could not be cannulated simply because of size or difficulty with line placement or dislodgement, as in they were unhappy with the way that it looked on x-ray, and therefore it was removed and needed additional access.
Dr. Padilla.
Hi, Ben Padilla from Phoenix. I just have a question about what type of dialysis machine you're using. Was it the Carpe Diem machine, which allows for much lower flows with a smaller priming volume, or is it kind of the more conventional CRRT machine that we're used to seeing in the ICU?
It's a similar hemofiltration with the smaller extracorporeal volumes, similar to the Carpe Diem, but not that particular model.
And then I had a quick question about, do we know the reasons for catheter failure? And if you're putting more than one catheter in the same patient, were you able to salvage the same vessel, or did that often require a second site?
Typically, we were able to salvage the same vessel. The complications included either bleeding from the line because it was either an untunneled line to begin with, and then we subsequently were able to wire out and place a tunneled line, or issues with malposition or just failure of the line to work. And typically, we were able to wire out and replace, so it did not usually involve an additional stick on the vessel.
Thank you so much.
Thank you.
Our next presentation will be from Dr. Sean Azadi, a general surgery resident at the Boston Children's Hospital. He will be talking to us about the effectiveness of intraoperative nerve monitoring in reducing rates of recurrent laryngeal nerve injury in aerodigestive and cardiovascular pediatric surgery.
Thank you for the opportunity to present. We have no disclosures. Surgeons often say that a chance to cut is a chance to cure. But when it comes to cervical, thoracic, or cardiac surgery, there lies an inherent risk of injury to the recurrent laryngeal nerve, leading to vocal fold movement impairment, or VFMI. Unfortunately, VFMI has a wide degree of presentation, from those that are symptomatic, such as with dysphonia, stridor, or respiratory distress, to those that are completely asymptomatic. And this makes us ask the question, why is this so important? Previous work from our group has shown that VFMI can affect up to 1 in 4 children after complex aerodigestive surgery. And contrary to popular belief that we should be on the lookout for these classic symptoms of dysphonia and stridor, almost half of our children did not present in that way. Just imagine this. You perform a great esophageal anastomosis, but the child is never able to use it because they aspirate everything due to recurrent laryngeal nerve injury. This makes us beg the question, how can we reduce these rates of injury? Intraoperative nerve monitoring does exist, but unfortunately the technology was built for adults, not children, in order to fit the smaller sized ET tubes. Because of this, we modified the existing technology for infants and neonates. But because of this allowed intrinsic limitations in the nerve monitoring data. Again, the traditional data was from adults, and no studies were performed using our modified technique, nor in the complex pediatric surgical patient. Because of this, we set out to evaluate the rates of vocal fold movement impairment in those with and without nerve monitoring, and we wanted to evaluate subgroups where nerve monitoring may have more benefit. We performed a retrospective single-center cohort study from 2018 to 2023, where we included patients that had both a pre- and post-operative flexible laryngoscopy to assess their vocal fold motion. They were children, and they underwent an at-risk procedure. We were able to capture 426 total procedures during this timeline, of which 307 underwent nerve monitoring compared to 119 without. We also want to highlight that our median weight of children was about 10 to 11 kilos, but we were able to accomplish this in children as little as 3 kilos. Our most common procedure was a combined airway esophageal procedure, and although the cohorts were largely balanced, those that had nerve monitoring were more likely to be reoperative. Now, to go along this journey with us, in 2018, we began screening our patients, but we were not using nerve monitoring. The blue graph represents the proportion of patients that were screened, almost 50%, and we had an injury rate at that time of about 16%. In 2019, we began utilizing selective nerve monitoring, represented by the yellow bar graph. And although our screening rates increased, so did our injury rates to 24%. But starting in 2020 onward, we transitioned to routine nerve monitoring. And as our nerve monitoring rates increased year over year alongside our screening rates, our injury rates dropped to, in 2023, being as low as 7%. So what does this mean in totality? Intraoperative nerve monitoring was associated with a significant reduction in postoperative VFMI, with those not receiving nerve monitoring having an injury rate of 20% compared to just 11% in those with nerve monitoring, resulting in a relative risk reduction of 44% and a number needed to treat of 12. Interestingly, bilateral VFMI was 14.4 times more likely if nerve monitoring was not utilized, with a rate of 5.6% without nerve monitoring compared to 0.3% with nerve monitoring. And additionally, nerve monitoring had enhanced protective effects in those with existing VFMI at the time of operation, with a rate of injury of 25% without nerve monitoring compared to 7.8% with nerve monitoring, resulting in a number needed to treat of just 3. After being ran through a multivariable logistic regression, nerve monitoring remains significantly associated with a reduced risk of VFMI with an adjusted odds ratio of 0.48. In conclusion, the implementation of nerve monitoring in children is feasible, but it requires a multidisciplinary approach to implement. With this, you gain an effective tool in decreasing recurrent laryngeal nerve injury and vocal fold movement impairment, and we recommend that it should be strongly considered in those with pre-existing VFMI. Thank you, and I'm happy to take any questions.
Rome Ignacio, San Diego. Wonderful presentation. Really like the potential impact of this. But can you go into further details about the procedures that was performed? Are there certain procedures that you would recommend? And then the second question is, talk about the anesthetic issues in relation to the nerve monitoring. But wonderful job.
No, thank you so much. So in 2019, we began utilizing this in selective cases, mainly reoperative cases where we'd be going into a reoperative field. But again, because of the benefits that we were able to see, we expanded it to all procedures, and now we use it routinely in all our esophageal atresia, tracheoesophageal fistula repairs, all our reoperative cases, and then what we would consider more bread and butter procedures involving the cervical and thoracic regions. As far as the anesthetic plan, I think that's a very important point. We have close multidisciplinary efforts with our anesthesia team, as you're unable to paralyze patients during these cases in order to have nerve monitoring work. Because of that, for a lot of our cases, we've transitioned to not using paralysis and using different amounts of other anesthetic agents in order to perform the procedure.
We had a question from the online chat. The participant wanted to know what exactly do you mean by nerve monitoring, and were there any circumstances in which you use nerve stimulation?
Yeah, thank you so much. So by nerve monitoring, we mean that we utilize a device that is able to preemptively let us know if we're accessing or touching the nerve. And so it's basically a wand that you use to stimulate the area that you're going to incise or cut, and it will give you a distinct tone if you're touching the nerve. And so when doing a neck dissection and you're on the lookout for the recurrent laryngeal nerve, you have an additional tool in your toolkit other than your eyes to be able to be on the lookout for the nerve. And it gives you that sound that lets you know that you're either on the nerve or not near a nerve.
Great job, Stephen Lee from Seattle Children's. Wanted to see if those patients that had the injuries, do you have any more information how that affected their long-term outcome and comparing it to those that did not?
Yeah,
Outstanding work.
Thank you so much. So we're actually working on that data right now, tracking their long-term outlooks. Right now, when we did in this study look at as far as the degree of injury, whether it was hypomobility or immobility, if it affected that, and it did not affect the degree of injury, but we're currently in the process of mapping out their timeline to see if this affected long-term prognosis. Thank you. Thank you.
Our next presenter is Dr. Ellen Cisco. She's a general surgery resident at the Mayo Clinic, and her talk is titled, What Happens Post-Malone? An Investigation of Long-Term Postoperative Management of Antegrade Continence Enemas.
Thank you for the opportunity to present. We have no disclosures to report. So why did we do this research? Well, we know that patients and parents often have questions preoperatively about the antegrade continence enemas and what's going to happen afterwards. And so we wanted to look more into this information, specifically talking to patients and parents about their postoperative outcomes and management. So as some background, we know that there's a 10 to 30% prevalence of constipation in children, and fecal incontinence can be a sequela of chronic constipation. Multiple etiologies are associated, including functional constipation, anorectal malformations, Hirschsprung disease, and spinal anomalies. There's a reported 50 to 70% improvement with initial medical management, but for medically refractory constipation, a surgical option is the antegrade continence enema, with three main conduits, the Malone appendicostomy, a neoappendicostomy, and a cecostomy tube. In the literature, there's a 60 to 98% reported success for patients with the antegrade continence enema, and there's a range of reported independence from the enemas with 4 to 43% reported in the literature. As I said, we wanted to look at our population of patients at 2 institutions with antegrade continence enemas, and then investigate the families and patients' perceptions of the antegrade continence enemas and how they use them, including whether or not they are able to wean from their use over time. So we started with a retrospective review of patients at 2 institutions undergoing appendicostomy or cecostomy tube placement between 2012 and 2021. And then we sent them a patient or parent survey asking about their perceptions and again, how they postoperatively use the antegrade continence enemas, whether or not they were able to wean from them, and if so, how. Overall results, there were 165 patients that we looked at, 32 at one center and 133 at the other, more males than females, and at these particular institutions, it was primarily appendicostomies that were performed. In terms of preoperative diagnoses, one of the institutions saw a little bit more, or had patients with more constipation or mixed constipation and incontinence as well as functional constipation, and the other we saw more fecal incontinence and anorectal malformations. Looking at whether or not they were able to stop using the antegrade continence enemas over time, out of the 165 patients, 36, or about 22% of them, did eventually stop using flushes. We wanted to see if there was a difference based on their underlying diagnosis, and did not see that there was a difference based on their underlying diagnosis. There was also no difference between the 2 centers on whether or not they were able to stop using the antegrade continence enemas. We did look into reasons for discontinuing. This was based on chart review as well as survey data. About 17% of them switched to an ileostomy or colostomy, meaning that the flushes in the antegrade continence enemas didn't work well for them. About 19% of the people who stopped underwent a laxative trial. About 17% presented with a stricture or obstruction that ultimately wasn't remedied. About 14% is just based on patient preference, and the remaining was kind of individual situations. Looking at this survey, we had nearly half of them responded to this survey. There was a variety of preoperative strategies with 75% on rectal enemas preoperatively. Asking of the respondents, we asked, how they if they were able to wean, how they did so. Was it on their own? Was it with assistance? And the majority used assistance from the team, but there was a portion of them who just did so on their own, weaning from using the flushes over time. Overall, there's still a high degree of satisfaction with antegrade continence enemas, with the majority of patients reporting that they were very satisfied overall and that they were very likely to recommend the antegrade continence enemas for similar patients. So like I said, overall, there continues to be a high degree of satisfaction with the antegrade continence enemas for children with chronic constipation and/or fecal incontinence. Some children may be able to wean off of the antegrade enemas with varied mechanisms, including patient and family weaning versus assistance in laxative trials. Thank you for your attention. Happy to take any questions.
That's great work. So you said that at those institutions it was mainly one type of surgery that was provided. Have you guys looked at how you counsel patients pre-procedure? And if a third of them are no longer going to need those, would you go with maybe just a cecostomy or something that's less reconstructive?
That's a good question. I guess I don't know exactly the conversation. I will say that even if the patients didn't end up using it over time or if it didn't work for them, pretty much everyone I talked to said that they were still glad that they went through the procedure and would have tried it again anyway.
Thank you for that great talk. Erin Tebow from Washington, D.C. One question I had, and what I think about a lot for our kids with any sort of antegrade enterostomy, is the influence of pelvic floor dyssynergia or anismus or sort of distal outlet obstruction. Is that something we could gather from your data or something you looked at?
That's another good question. I don't have a specific answer for that right now, but that's a good question.
Yeah, hard to capture, but worth looking at. Thank you.
Thanks. Thank you.
Well, that talk transitions nicely into our next one, which will be presented by Dr. Thomas Hsu, the Colorectal Research Fellow at Children's National Medical Center. He'll be talking to us about a bridge to continence, utilizing an antegrade continence enema program to treat soiling and as a transition to voluntary bowel movements.
A little different flavor of Malone here. We did this research today because imagine the child that comes and presents to you with constipation, who continues to soil and has failed all sort of medical management. How do we treat this difficult problem? What we're going to present today is important because we're going to show how an antegrade continence enema program is not only effective at getting patients clean of stool, but can also help them transition to voluntary bowel movements and achieving true fecal continence. To start, it's important to understand the patient's potential for continence and their underlying cause for constipation. On one end of the spectrum are those with a poor potential for continence, such as those of neurogenic bowel or those of anal rectal malformation with poor features, such as having a high fistula, tethered cord, or poor sacrum. These patients probably should expect to have antegrade continence enema therapy only. However, on the other end of the spectrum are those with a potential for continence, such as those with functional constipation, Hirschsprung's disease, or anal rectal malformation patients with good features. For these patients, we want to stress that the ACE can be used as a bridge to continence. As we've just discussed, it's well known that ACEs are a very effective surgical option to help treat medically refractory constipation. Roughly 70-90% are successful at achieving bowel cleanliness. But what next? What happens after that? Most patients and families want to know how long they'll need the ACE for, or have the perception that the ACE is a permanent solution and they'll have to be on them forever. Again, we stress that the Malone or the ACE is a bridge to achieving voluntary bowel movements. However, the success rate and timing of this transition from becoming clean of stool to having voluntary bowel movements is unknown. Therefore, the objective of our study was to explore the rate and timing of successful transition from ACE therapy to voluntary bowel movements and associated factors. We performed a single institution retrospective review of children with the following diagnoses between 2020 and 2023 and had at least 6 months of follow-up. We excluded those with neurogenic bowel, spina bifida, and ARM patients with a poor potential for continence, as these would not be expected to achieve voluntary bowel movements, and we counseled these families on this. Our primary outcome was the rate of transitioning off ACE therapy to voluntary bowel movements using laxatives only. Our criteria for transition was if they were at least on a 6-month regimen that was stable, they were able to hold in and control the release of flushes, and if the family and the patient were desiring and able to participate in a 1-week bowel management transition week. 100 patients met inclusion criteria in our 3-year study period. A majority of them were male. Our median age at the time of receiving ACE was 8.6 years, and our median follow-up time was 17 months. A majority of our patients had anal rectal malformation, followed by a third with functional constipation, and a fifth with Hirschsprung's disease. How did we do? Well, 88% of our patients became clean of stool in our study period. But again, what's next? How many no longer needed the ACE? Regarding our primary outcome, we found that 16% were able to transition off ACE to laxative therapy only. By diagnosis, 24% of our ARM patients, 12% of our FC patients, and 11% of our HD patients were able to transition. However, this was not significantly different on chi-squared analysis. When we did a univariate logistic regression, we also found that no factors were associated with transition to laxatives. And these include basic demographic factors, the underlying diagnosis, childhood opportunity index, and presence of a concomitant neurotypical diagnosis. We then estimated the time for these patients to become clean of stool, not become clean of stool, to transition, and we found that the median time to transition to laxative therapy was 15 months, with the earliest time of transition at 7 months and the latest being 28 months. We also had some other notable findings. 14 of our patients were ready for transition, but they had to still schedule for their 1-week transition week. And 9 patients were ready to transition, but they actually preferred to stay on their ACE, and they specifically requested to stay on the ACE therapy. Regarding limitations, this is a single institution study with a dedicated bowel management program, so our results may not be as generalizable as we like to institutions that may not have the same resources. Second, the median follow time is relatively shorter compared to other longer-term studies, although none of our patients relapsed during our study period or had to go back to using the ACE. And again, significant factors may not yet be apparent yet due to our shorter follow-up time. So in conclusion, antegrade continence enemas can bridge patients to voluntary bowel movements. We found that 16% of our patients can expect this transition in about 15 months. And we think this is really important because this information can help set expectations for patients and families who are considering an ACE. Thank you to the entire team at Children's National for making this research and care possible.
Great presentation, and someone who tries to study this, there's so many different variables.
Yes.
But I want to try to make sure I understand this correctly. And Jason Fisher from Cincinnati. The variable you looked at to transition was if they're able to hold their enema and then expel it. Is that correct?
It wasn't a variable. That was just one of our criteria for determining when they can make that transition. If they're able to hold in their flushes and kind of be able to release it like voluntarily.
Okay.
On the flush program.
So did you test that before they got their ACE to see if they were able to do that? And if you did, what did you do to get them to change from being able to hold it to not being able to hold it to being able to hold it?
We didn't test that because, again, a lot of these patients, their issue is they have a hard time doing this, and we believe that the ACE is actually what enables them and kind of enables them to be able to learn how to hold in these flushes. Or hold in stool, basically. The ACE becomes like a way to practice holding in stools correctly.
Yeah, so I agree, and so I wonder, do you have any criteria of when you transition to patients other than what you mentioned before? Because I don't know when to offer it. I sort of make it a family and team decision to say, hey, we're always willing to try to get you off antegrade treatment, and that might be 15 months or it might be 15 years. I've had patients in their 20s transition off. So I just didn't know if you found any variables that sort of hinted when the right time was to do that.
I think we don't have any hard variables, and I think that would be another interesting direction to take the research to really pin down on factors that would predict like imminent transition. All we really have is if they had a stable flush regimen, and then again, if they had this ability to hold in the flushes. It'd be interesting to look at like for how long they can hold in the flush or how long they can kind of.
If there's no other questions, I'll ask one more.
Yes.
This is great. If the patient didn't have a stable flush regimen, did you still offer that?
We're going to have to move on.
We don't. We don't think that they're ready. And, we usually don't broach that subject just yet. Thank you.
All right, our next talk is from Dr. Scott Eldridge, a general surgery resident from Phoenix Children's Hospital, and his talk is titled Outpatient Opioid Monitoring and Reclamation Program Following the Minimally Invasive Repair of Pectus excavatum.
Thank you, that title's a mouthful. We have the following disclosures, We chose to pursue this study as opioid misuse is commonly set into motion through the diversion of prescribed opioid medications. Opioid misuse is becoming more common in the pediatric patient population, with a reported threefold increase in pediatric-related deaths over the last 2 decades. This work is important as it highlights our continued effort to improve our opioid stewardship following surgical intervention in this vulnerable group of patients. The minimally invasive repair of pectus excavatum is a painful procedure. This is evident by high opioid requirement and a prolonged hospitalization following repair. When compared to other analgesic strategies, cryoablation is shown to improve pain, decrease opioid inpatient requirement, and reduce hospital length of stay. However, there's a wide variation in the amount of opioid that's prescribed following this procedure, and little is reported on the effect that cryoablation has on the outpatient opioid demands. In May of 2023, we instituted an opioid education, monitoring, and reclamation program to better understand outpatient opioid use following this repair, in addition to reduce the number of unused opioids in the community. As part of this program, patients were provided education on the appropriate use, dangers, and disposal practices of opioids. Patients were provided with a questionnaire to query them on their opioid use in the outpatient setting and how they plan to dispose of their opioids. And patients were encouraged to bring any unused opioids to their first postoperative visit to dispose of in our clinic disposal bins. If they did not bring opioids to this clinic visit, they were provided with a charcoal-activated disposal pouch that they could take home for disposal. So with this background, we sought to assess the duration and the amount of opioid use in the outpatient setting following the minimally invasive repair of pectus excavatum. We also sought to examine opioid disposal practices among these patients. To do this, we conducted a retrospective review of our pediatric patients who underwent the minimally invasive repair of pectus and who completed the questionnaires. We then reviewed patient demographic, post-operative inpatient opioid use, and outpatient opioid prescriptions. Further, we reviewed the questionnaires that queried patients on the amount of opiate that they used, the duration of the use, and their disposal plan of any unused opioid. We quantified opioid use in terms of oral morphine equivalents and in 5 milligram oxycodone tablets. We then used descriptive statistics to describe our findings. In total, 72 patients were involved in the opioid stewardship program, of which the majority were male, with a mean age of 15 and a median Haller index of 4.3. The median length of hospital stay was 1 day. During hospitalization, patients required an average of 38 oral morphine equivalents, or approximately 5 milligram oxycodone tablets. At discharge, patients were routinely sent home with 10 oxycodone tablets. Following discharge, approximately 20% of our patients required an opiate refill. This resulted in us prescribing a total of 920 oxycodone tablets to this group of patients. They reported using oxycodone for approximately 5 days, and each patient reported needing at least 6.6 oxycodone tablets following discharge, or a mean of that. 92% of our patients reported having 420 oxycodone tablets that were unused, which accounted for about 45% of all the unused, or all the prescribed opioid in our study. We then looked at opioid disposal practices among patients that had unused opioids. We found that almost half of patients that had unused opioids planned to not dispose of them. We also found that 37% of patients planned to use the clinic or charcoal pouches that were provided. And 14% of patients said that they would dispose of them, but they reported that they were unsure, or they indicated they would use the trash can or the toilet. The patients that had no plan to dispose of their unused opioids had about 200 oxycodone tablets, or about 50% of the unused oxycodone. Each patient had approximately 6 oxycodone tabs. The greatest limitation to this study was the use of a questionnaire. Patients were subject to recall bias. We did not actually count the number of unused oxycodones they had. To mitigate this, we had them complete the survey or questionnaire relatively soon after discharge. Additionally, patients may have been dishonest with how they responded on the questionnaire due to a possible negative connotation that may be had. We also conducted this at a large freestanding children's hospital, and the results of this study may not be generalizable to all centers. And finally, we recorded the disposal plan and not actually how they disposed of their opioids. We've now set into motion an automated telephone message that queries patients on how they've actually disposed of their opioids. So to conclude, despite a relatively conservative prescription practice, Approximately 50% of the opioids prescribed following the minimally invasive repair of pectus excavatum go unused. Even with an opioid education program and an easy means to dispose of the opioids, approximately 50% of all the unused opioids were kept by families. In the future, we will need continued opioid stewardship to decrease the amount of unused opioids in the community. This includes providing a standardized guideline for writing prescriptions following this repair, identifying patient risk factors of non-disposal, and creating a mathematical model or a model to help us prescribe the correct number of opioids for each patient. Thank you, and I'm happy to answer any questions.
Thank you, great talk. I'll start with a question. So have these data led you to prescribe fewer opioids?
So, it's interesting that you asked that question. We've actually created a model to help us aid in the number of opioids that patients would need. We're now implementing that based on their inpatient opioid use. When we looked at the median number of oxycodone tablets used, less than 75% of patients use 10 or less. So, we are working on a way to decrease that. And we'll see how it goes. So, we'll have to look at that prospectively or retrospectively, or as a quality improvement project in our center.
And are you using adjunct pain medications that would allow pain control with non-opioid methods?
Yes, sir. Yeah. So, thank you for that question. As part of our opioid package, we have a multimodal pain regimen. The biggest of that is cryoablation, but we send patients home with Tylenol and ibuprofen for pain relief as well.
Things like gabapentin are also options?
So yeah, we used to use gabapentin, but as we looked at our results, we found really no difference in pain scores between patients that had gabapentin versus those that didn't. As one of the limitations of our center is we get patients from far distances, and to make gabapentin really effective, they need to start it about 3 weeks before the surgery. So we compared those group of patients that didn't get it to those that got it, and we found really no difference. So we stopped using that at our center.
Okay, thank you.
Rom Ignacio, San Diego. Scott, again, a great presentation. I do think you should push yourselves even further, especially with all the work that Dr. Kelly Kwan has done for opioids. There are many of us in the audience have now gone to the point of trying not to even prescribe those opioids. It is true that there's the question about gabapentin hasn't been answered. Some of us do it and some of us don't. But I think a good study that I know that some individuals here are working on is important. But I do think for us as surgeons, we really have to push that even further to the point that, some of my patients, I don't even send any opioids whatsoever. And I think it's that education, that expectation, but great work, especially in trying to push the envelope of decreasing opioids for our patients.
Thank you, Dr. Ignacio. I really appreciate that comment. I agree that there is room to move still. We balance that with the patients going home and are being in pain. One of the limitations of our center or differences of our center is we serve the entire state of Arizona. So we have patients that come from 3 or 4 hours away to get this repair. So we try to make sure that they're not going to go home and be in pain by themselves 3 or 4 hours away from our center. So there is a balance, and we are working to decrease that still.
Thank you.
Thank you.
Our final talk of the session will be given to us by future Dr. Amelia Gavulik. She's a medical student from the University of Cincinnati College of Medicine, and she will be talking about the association of pain and quality of life in children and adolescents with pilonidal disease, a multi-institutional study.
Good morning. My name is Amelia. I'm a rising fourth-year medical student at the University of Cincinnati. Thank you for this opportunity to present today. I have no disclosures. Greater than 50% of pilonidal disease presents with acute infection, which can be very painful. Since this disease largely affects adolescents, associated pain can lead to impaired physical and social functioning at a critical point in development. We sought to identify factors that impact quality of life in these patients in order to inform treatment algorithms and further optimize psychosocial outcomes for these patients. This was a multi-institutional observational cohort study done by the Midwest Pediatric Surgery Consortium. 10 pediatric tertiary referral centers participated, from 2019 to 2022. Included patients were those with symptomatic pilonidal disease, ages 12 to 21, and they underwent primary surgical or primary medical management. They were followed for symptoms and complications by clinical chart review and surveys at intake 1, 6, and 12 months. Patients treated medically were mostly treated with hair care and lifestyle modifications, and patients treated surgically were largely treated with gips trephination in our patient population, but a select few also underwent wide local excision or excision with flap reconstruction. Patients could switch management strategy during the study, and there's no consensus on optimal management strategy at this time. The patients were surveyed at intake 1, 6, and 12 months for symptoms, recurrence, healing status, and quality of life scores using the PEDS QL 4.0 inventory. This inventory scores from 0 to 100 with a mean clinically important difference of 4. We then investigated drivers of quality of life in our statistical analysis. The average age of our patients was 16.6 years. They were about half male and half female, largely Caucasian, and the mean BMI was 29, and our patient population was largely overweight and obese. As expected, more patients reported 0 days of pain over time. There was a significant reduction in patient-reported days of pain as the study progressed when compared to 1 month. Average quality of life score also improved over the course of the study. As previously mentioned, the mean clinically important difference in the PEDS QL 4.0 score was 4. Patients started at an average of 78.6, significantly increased to 81.8 at 1 month, and 84.7 at 6 months. There was no significant increase from 6 to 12 months, and the 12-month average was 85.3. We constructed a multivariate analysis which identified days of pain within the last month related to pilonidal disease as a predictor of quality of life score. Pain acts in a dose-dependent fashion, with more days of pain being associated with significantly lower score quality of life. Scores were significantly higher for patients reporting 0 versus 1 to 7 versus 7 days of pain, with those average scores being 84.2, 81.4, and 74.3 respectively. Our multivariate analysis also demonstrated that positive opioid use for pain control related to pilonidal disease also predicts quality of life, with patients reporting opioid use having an average score of 78.3 versus 81.7 for those who did not use opioids to control their pain. Healing status at 12 months also predicted quality of life score, with those reporting healed disease at 12 months having an average score of 82.0, which was significantly higher than those reporting lack of healing at 12 months, with an average score of 78.0. In conclusion, pain, narcotic use, and non-healed disease are predictive of poor quality of life in pediatric patients with pilonidal disease, independent of treatment strategy. Resolution of pain and healing should be considered to optimize psychosocial outcomes in these vulnerable patients. Pain should not be a deciding factor in management strategy. However, pain control is one of the drivers of poor outcomes in these patients, which is perhaps a call to action for improved pain control. This work was supported by the 2019 APSA Foundation J. Grossfeld Scholar Grant, and I would like to thank my PI, Dr. Remeski, members of the Midwest Pediatric Surgery Consortium, specifically Jennifer Knox. Thank you, and I'm happy to take any questions.
Hi, Jim Pierce, Valley Children's. Fantastic presentation. Congratulations. And just for our orientation, for the PEDS QL 4.0, if a regular teenager walked off the street, what would be the usual expected number that they would score to compare to people without pilonidal disease?
That is a great question, and I cannot remember the number off the top of my head, but it is in the 80s, I believe. It's not 100.
Great work, great presentation. Stephen Lee, Seattle Children's. I'm curious, and you may not be able to look at this in the data, but what was the main cause of these patients' pain and requiring opioids? I'm just wondering if whether a different treatment strategy is actually needed versus the kind of ad hoc that was allowed, because don't recall having a lot of patients on opioids unless it's around the time of an acute infection.
Sure. We might have to dig into our data set a little bit more for those, but the question was phrased specifically pain related to your pilonidal disease, so just to eliminate any other reasons that they might be having pain in their day-to-day life.
Thank you.
All right, thank you to all the presenters for their outstanding abstracts. We invite everyone now to go pick up your lunch from the foyer and then come back to this room for the business meeting in Town Hall.